And now we invite your questions, and he's ready for them. Dennis has a microphone, and I do too. We'd like you to ask your question into the microphone. So please, if you have questions, just raise your hand, and we'll go back and forth, okay?
And also suggestions are fine.
You can introduce yourself too, your name and organization. Oh, I'm sorry.
Bob Derry from Plant Moran. I work in the healthcare group. For your fiscal 15 budget, what are you expecting from percentages of increases or decreases? Or is it going to be certain parts of the budget are going to have increases, certain parts of the budget decreases?
Well, one of the great things about a budget process, I don't say anything about it until the governor releases it on February 5. So it's usually simulcast so you can catch it then, but this is a very robust budget.
John Dennison from Gleaners. I have a question regarding all the data analysis that you have in your warehouse and your data. Are you doing anything to help promote the quality or measuring the quality of care people get at the local hospitals or the local care level?
Now, the quality of care measurements is something, if you look at what Skip Campbell's doing at Michigan, you look at what we're doing with the MyPick program with the primary care providers along with Michigan and Priority Health in the department, you're seeing all of this shifting into quality measurements. And we're moving that way quickly. And you're going to see when we rebid the managed care contracts in the state, and that date has been not finalized yet, it's going to move from a lot of output measurement to outcomes. And that's the way I think we can begin driving the system. I have to figure out a way, or we have to figure out a way to start attacking these chronic conditions. And I'll tell you, a lot of the things that many of you have done with walkathons and getting healthier food into schools, getting education out to your employees, the new employee contracts you've got with your employees that focus more on wellness and benchmarking, you're doing a favor to your employees because they're all going to live longer because of it. And continue to do those type of things. It all works. Yes?
Hi, Jim. Kerry Walker from the Guidance Center. Last fall, the state issued a RFI for social impact bonds, and a number of the organizations in the room responded to that. Do you have anything that you could tell us about where the state's at in the process of social impact bonds and these kind of new methods of financing innovative ideas?
Social impact bonds is really fascinating. They've hired a Harvard fellow who's come in to kind of manage this, and they've narrowed this long list down to about 8, and I think they're trimming that down to pick 1 or 2, and then foundations will partner and to invest in that project. So I had a meeting about 6 weeks ago, and that was the status at that point. So it's moving along. And I also think it's available to many of you in this room with your own local foundations to talk to them about social impact bonds or investing that they might want to do in some innovative ideas. I mean, what's going on in the hospitals is something that's going to hit all of us here, which is cash. Cash is king. And if you got cash and you got investors and you got people, and I think in the nonprofit world, we have to figure out how to get venture capitalists and other investors to come up along with us, invest in what we're doing in the nonprofit world, and I have no problem with them getting some return because they operate like a bank, but they have that social commitment, and they might recognize they might not get it back. But I think we need to find new avenues of cash to do what we want to do, and that's one of the things I think that could really help us. Yes?
But by the way, the next session of our series is on social impact bonds, and we have a fellow from Harvard coming.
Boy, what a lead-in that was. That was great.
Thanks for that.
Kirkjude Goddard from JVS. As a private, not-for-profit, I'm curious as to how you view in the future, will there be a future for small not-for-profits, or do not-for-profits have to really start looking, you mentioned mergers and affiliations, do not-for-profit entities have to start looking at, coming together, maybe forming some mergers in order to defray administrative expenses, become more efficient? Yes,
I think you do. I think there's a lot of different models out there from administrative organizations where you pool backroom work and still maintain your individual autonomy. I think you're going to see more for-profit people acquiring nonprofits, much like we've seen in the hospital world. Venture capitalists in Michigan right now are investing heavily into healthcare, into a lot of the for-profit startup companies. They don't know much about the nonprofit world because we haven't done a very good job telling them what we do. And we've always kind of been afraid of venture capitalists. Well, they have cash, they have interest, but they also have networks, and they bring a lot to the table. I in my own mind, haven't figured out all those models, but I think it's going to be very difficult if you're a small 6, 8, 10 person agency to survive in a very competitive market in the future, and yet you're going to have to find new relationships and partnerships.
Hi, Paul Propson, Covenant Community Care. We have, by the way, thank you for your advocacy for Medicaid expansion in Healthy Michigan. It's a huge, huge breakthrough for us. We're enrolling people through Maximus, kids and pregnant women, I think. And we're enrolling adults who are above 133% of poverty generally into the healthcare.gov portal. For the adults below 100% of poverty and below 133% of poverty, should we be applying through Maximus in February,
No.
in March?
No, not until we tell you.
Okay, so fill out the healthcare.gov applications
Right.
presently for that group.
Right.
All right, thank
Of
you.
the 322,000 people who will be eligible, we think, that will sign up the first year, 70,000 of those are between 100 and 133% of poverty. The bulk of the people are between 34% and 100% of poverty. And that's a group that we really have to get health care to. Now, this is going to be an interesting group. There's going to be a higher rate of depression and mental health in that group. There's going to be a higher rate of alcoholism in that group. I'm really concerned about, the president's comment yesterday about, well, pot's not as bad as alcohol is going to bring an interesting debate. And we as parents and grandparents, it just sent shivers down my spine. Like I used to run Project Rehab, a drug program in Grand Rapids. But I know the struggle we got with alcohol use in this state. And I know the 350,000 pathological gamblers we have in our state. And many of those are also alcoholics. And you bring other illegal drugs in there. I don't know how we're going to handle this. My big concern, in fact, on one of the innovation funds I funded was a program that Hope Network is doing called Pitch for Kids. We have tens of thousands of alcoholics, families who have kids they're raising. And if we don't break that cycle, we're just going to have alcoholic kids growing up into adults. And many alcoholic parents don't want their kids to be alcoholics, but they're not going to change. But we can't remove all these kids. So what they do is to go in, and we're going to do this in Flint, is to work with the kids on a 2-day session, and then the third day they bring the parent in. And what we're going to try to focus in is giving kids the skills to survive without being victimized and give them some control over their future. And to work with the kids, see if we can't start breaking those cycles. And if you saw some of the statistics that the federal government put out this week, were really overwhelming about if you're born into poverty, what's your plight in life? And I think we can do better than what the statistics are saying, but it is tough, and that's where we've got to break some of these cycles to give some stepladders. So folks can get into what the president calls the middle class, which I really believe that we have to work on. But we got to break some cycles, and the alcohol use around the country just continues to increase, and it's really devastating to families. It's something that we all got to pay attention to. Yes, ma'am.
Hi, I'm Claudette Bond from Advantage Health Centers out of Detroit, Michigan.
Good.
You referenced parental skills, and I'm wondering, have you considered approaching NAMI, National Association for Mental Health, or the AMI group here out of Oakland County? They offer a great Families in Action program.
Well, I haven't, and if there are resources we can use out there, so, I'm an easy one to email or write a letter to. That's the other thing difference. When I took this, that's the second thing that's different about this job. When I took this job, I walked in the office in August 2012, and I says, where's the spindle for the pink notes of all the phone calls I get? Because I remember under Engler, I would walk out of the office, grab all those pink slips, and get in my car, and I make the calls. And they just looked at me, and they finally found a spindle in the archives. But I bet you in a year and a half now, I've got 10 calls with the blue things. I mean, everything's by email, everything's by phone. I mean, I created a crisis when I got there. I said, because I dictate letters. And I said, how do I dictate? And they all looked at me like, we don't have any dictating machines. I mean, it's really changed. And so I've had to adapt, and including, a couple of my comments this morning were, on my iPad. But that's just where it is. I can walk through the office and tell you everybody who's under 30 because they got a clean office. And you know exactly what I'm talking about, because we hold on to that paper.
Good morning, Jim. Roger Myers with
Sure,
Presbyterian
Roger, good to see you
Village,
again.
Michigan. Would you offer your comments, perspectives on PACE programs, and then secondly, what you think could be done to take those programs to scale and to take some of the competencies that they have maybe in other areas?
I like PACE programs. We started one in Grand Rapids 10, 12 years ago. Henry Ford has been a pacemaker here. You're going to see recommendation to expand the PACE programs, and one of the things that has limited us to expand a lot of things in the world of the elderly is that I've had to get separate allocations in my budget. And I'm pushing in 2015 to roll long-term care up into one line so that we can pick and choose accordingly based on the needs of people. So that's one of the things that we're doing, but you're going to see expansion of it.
Good morning, Jametta Lilly, the Wayne Children's Healthcare Access Program.
How are you?
Yes, thank you. You talked about earlier the whole need for integration, and certainly it's wonderful to see how that's occurring in behavioral health as well as primary care health. And 100 years ago, when you were previously with, which was in CMH, we used to have the multi-purpose collaborative bodies. And I'm wondering, since we all know that when we look at social determinants of health, that it's not just us in health that can make a difference. It has to have social services, education, et cetera. In what ways is it happening at the state level that, in particularly, that there's some more integration, and how is that being supported with policy and financing to assure that education, health, behavioral health, and social services are genuinely planning and pumping out the resources to us in this room so we can actually function in an integrated effort?
I went back, and Connie Bensfeld recently passed away, and many of you knew her. She was a grand lady, but she had the Bensfeld Commission, and I was on that along with Jerry Miller. If you remember, Jerry Miller used to be at DHS, or Family Independence Agency. Then I went back and read, Jerry Provençal and I were on the Unification Committee, in 1940, I think it was. No, it was 1980. And then there was a commission report in 2004. I don't know if some of you were on it. And whenever you got to the point of integration of DHS and education, we always stopped at the point of, and it all came down to funding. All came down to blended dollars. Nobody really wanted to pool their dollars. And if you remember Annette Abrams, and by the way, I spent some time with Pat Babcock the other day, which was really fun. But they tried to set up a children's unit within Family Independence Agency way back when. That didn't work. And so then we did the collaboratives, and then Beth Leeson was part of a group, and she used to work for me. Then we did a study, but we never got to the point of. And so now that I'm chairman of the People Group, which for the cabinet means Maura Corrigan and civil rights and education, we are having some. There are going to be some specific recommendations in the report that's being released today. That's going to start tackling why it's not happening, and that's funding, that's coding, that's reimbursement, that's talking about blended dollars, one person being in charge and having all the money, and then on a per member per month, they're on a risk sharing. making sure wherever that child is, whether in Wayne County or Oakland or Kent, if they move around to different groups, that one agency's following them, so there's some continuity. So you're going to see some things finally come out that I think is going to drive it home of where we wanted to be over all these decades. So.
Morning, excuse me, morning, Jim. Joe Ferguson, Advantage Health Centers. And basically more a commitment than a question. As the department begins to work on the Healthy Michigan rollout, just to let you know that within Wayne County and the local community, we have a strong network of outreach and enrollment individuals through the federally qualified health centers, the health systems, the governmental entities, the community mental health centers that have been meeting for the last several months as part of the Affordable Care Act. They're also available for Healthy Michigan. So as your department, working on limited funds between now and April, need to reach out or have assistance, feel free to contact us in the community. We'd be more than willing to help you roll that out. We have a strong network of volunteers. The FQHCs were funded for this endeavor, and we want to help you make that a successful rollout.
Make sure before I leave here today, I have 1 or 2 names that I can give to Geraldine that she can call who will get everybody in Wayne County and Oakland and Wayne. We cannot, my goal is that when we roll this out in April, that it is so smooth and there are so many people that sign up that the Republicans and the Democrats just, it's a wow factor for them. And it's a real awareness that these folks are out there and that they want to sign up, and we know their profile. I'm going to make sure as we evaluate this that we roll out vignettes as the program goes. I want to be very transparent on this. And if you take a look at, there was an article recently in the New England Journal about the Healthy Michigan Plan. I see that as the first chapter. And then we'll do a report on how the rollout went and how it went with enrollment groups. But we cannot do this without you. And it's going to be a simple form of 3 pages. It's not an asset test. This can move fairly quickly. And once those computer systems, and you know, if this, with the MAGI system coming on board for Medicaid, with the Healthy Michigan Plan enrollment through Maximus, within a couple years, the only thing left for DHS to do an enrollment will be basically blind, disabled, and aging. And if you look in the Healthy Michigan Plan, we have to have within a year a plan to the legislature as to how that enrollment will be done. So there's already thinking going on about how that can be done. We're an aging state, so you're going to see a lot of emphasis on aging issues.
Jim, hi. Excuse me, I'm Mark Milgram with Jewish Family Service.
Hi.
I have a 2-part question. The first is, how have term limits in the legislature affected the way that you educate and lobby legislators? And secondly, what advice do you have for us when we're trying to lobby legislators?
I found out when we started the Healthy Michigan Plan that I was starting over here and the legislators were over here. And Steve Fitton and I and a few others, we just started one-on-one and sitting down with groups of 3, both in the House and the Senate, and educating them about a basic 101 on this is Medicaid, this is Medicare. Most folks didn't know we were a managed care state. Everybody said, why don't we do what Florida's doing in ARCO? Well, we did that 17 years ago. And we had to go back to the basics. And I think sometime when we lobby legislators, we assume they know what we're talking about. And I think we got to be real basic. And there's nothing like getting people walking in your programs and seeing what you're doing. I don't care if a Republican is running or a Democrat, engage with both of them in the primaries. Support those who you want to support. Go to their office. Have them visit you, invite them to your events, have them meet your board, have legislative breakfasts. I know some of you do that. That is the way they get educated. And I can tell when the Oakland County people are understanding what Jeff is doing because he's met with them. Or what's going on with the Jewish Federation or Access or many of the other groups that have met with their legislators, and many of you do that on a regular basis. But it helps me and it helps them. And there's some new members of our Appropriations Committee, Mike Shirkey from Jackson, Jim Stamas from Midland. They need to be brought up to speed. and things will happen very quickly. So you got to keep repeating it. I'm just amazed the number of people that say, we talked to our legislator, and there's no reason to talk to them again. It takes a repeating and a repeating and a repeating on a first name basis. So term limits is not going to go away. Term limit isn't going to change. And we just got to adapt to it accordingly. So just keep doing what you're doing. And for hospitals, they got multi-client lobbyists, they got PACs. Many of us don't have multi-client lobbyists, many of us don't have PACs, but we got our consumers and we got services. And I'll tell you, that means as much as money. And when they see the outcomes of what we do for people, that's extremely gratifying because they never see the outcomes of what they're funding. And we've got to do a better job at showing them that. Yes?
Hi, Jim. Jerry Provençal, Macomb Oakland Regional Center. Many of us in this room have worked with you over the years quite passionately to closed institutions, particularly for people who have developmental disabilities. And now that Mount Pleasant, the last institution in the state, has been closed, and there's a safety net that receives funding from the state, things are looking pretty good. On the other hand, there's not really a uniform acceptance by all the boards in the state to not use, to keep from using physical intervention. And in some cases, we are hearing more and more about larger group homes being opened and even private institutions being opened. People in the jails, we understand up to a third of the people who are in jails have psychiatric diagnoses and are receive proper training. And I'm wondering, and treatment, I should say. I'm wondering what your thoughts are for the future now that we no longer rely upon an institutional system to take care of people who present exceptional challenges. What the state might do, I know we're doing things individually in various regions of the state, but what the state might be able to do to encourage something that's really across the board, providing the best care and the best kind of safety net for everyone in the state.
No, good question. I really get frustrated when private psychiatric units in this state don't want public patients. You cannot, for most psychiatric units in this state, to get your CON, you got to commit up to half your beds to the public patient. And one by one, I've been calling them in to meet with our staff to see what's going on. Because if you got 8 vacant beds and you turn down a public patient from Oakland County or Macomb or Wayne because that person's bipolar or is too tough to handle, then that hospital better figure out how to handle that patient. And why should that person end up in jail or on the streets? And so we got a lot of pressure on those groups right now. Secondly, you're going to see a lot of effort. You saw a lot of efforts on the mental health courts and the drug courts. I got to continually, back in the 60s, I sat down in Kent County and we wrote the first LEAA grant, if some of you remember those, to start diversionary programs in the Kent County Jail. There were mentally ill people in the jail at the time. And I get a little tired of people saying there were never mentally ill people in jails until we closed state institutions. Not true. But for those we can divert, we should, and that means better education of the law enforcement community. That's why we put out $1 million on the mental health first aid type training. You're going to see very aggressive diversionary programs. There's money in our budget this year. There'll be money for next year to expand diversionary programs with the Community Mental Health Board, the courts, and the sheriff. We're not going to support many institutions in this state. We're committed to the structure we've had in the past. We have 2,000 private psychiatric beds in this state. We don't need more state hospitals. So you're just going to see us hold what we have accountable and tighten that up. You're going to see new recommendations in the Commission's report on accountability of adult foster homes. You're going to see some recommendations on diversion. So I think, Jerry, I think we're addressing this as aggressively as we can. But I also got to trust the community mental health system, who funds many of these programs, to hold people accountable, but also to think. We have a hole in the system between crisis beds and a 30, 40-day psychiatric bed, because we have some licensing issues of really challenging people that we can't keep in the community that we could if we had the proper settings. And so we got to figure out how to do that. So that's what we're looking at. And I remember when Rose Hill, Benzat, was supported. I remember, it's a private public campus in Oakland County. There's Benjamin Hope that caught some criticism in Ottawa County. If you visit it, it's a campus of I think about 6 apartments in a neighborhood. There's such a thing as parent choice and consumer choice that we got to forget about, and it's not all what advocates think it should be. So we got to really, and I'm a real believer in consumer choice, and I'm a real believer in empowerment and self-determination, and we've got to respect that. And I think when the new CMS rules that came down, left a lot of that discretion up to the state. But we're putting a lot of heat on available beds. I'm not going to let this system beginning to stack up because people who should be providing services aren't. I get really upset when kids are waiting in DMC, in the Children's Hospital, and are sitting in the ER room for 7 days. Something's not working. And we're going to come a knocking because that should not be. Yes?
Yeah, Jim, in reference to your earlier comment about the 10 regions and potentially standardizing those regions for a variety of different agencies, what's your thoughts about the 16 different area agencies on aging and whether those would get folded into the 10 regions?
If I were public health people, if I were aging people, if I were community mental health people, if I were many people who provide services, I would begin looking at those regional maps.
And one final question.
Yeah, Jim, Ben Robinson, Rose Hill Center. Seems that we have an unfulfilled promise as it relates to mental health parity that's been played out at the federal level. We have regulations that haven't really come down. You touched on residential treatment and some of the licensure issues, but in the exchange programs, even in some of the Medicaid programs, we're not seeing the opportunity for residential care, crisis beds, non-hospital care. We're seeing either hospital or outpatient. Wondering what the state can do to encourage the feds to move forward with really bringing out some regs that'll let this fulfill its promise.
I think there's not the votes in the Michigan House and the Senate right now to do mental health parity. I think the essential benefits under the Affordable Care Act go a long ways to offer that parity. The Healthy Michigan Plan is going to have a very healthy benefit for substance abuse and mental health in residential care in non-psychiatric settings. So look for that, and we worked hard to make sure that that got in there. Public health, I saw George Miller here, but public health is really key to a lot of what we do, and there's not enough of you that know your public health person. And population health is a word that we're going to use a lot. You're going to hear us talk a lot about the experience of health care. Many people don't have a good experience in health care. We have dozens of people in the hospital and University of Michigan right now with the flu. We got many people in this state, dozen people in this state on life support because they didn't get a flu shot. Some of you didn't get a flu shot. That's all preventable care. So we got to practice what we preach, folks. And only 4% of the kids on our college campuses in Michigan got a flu shot. We can't get the presidents engaged, and this is an important thing to do. So I appreciate what public health people are doing is trying to drive that message, but we've got to do a much better job on this whole chronic care area and arena, and that's where we are really going to need our public health colleagues stepping up to the plate and partnering with you. But overall, the indicators are starting to move in this state. We all got to double our capacity to make things work. There's room for everybody in this room. We're not trying to exclude anybody. And only by taking down the fences can we move this forward. And I appreciate everything you're doing, and I thank you for your time.
Thank you, Jim. Well, thank you for your attention, and please take note of the evaluation forms and really value your feedback. So the green forms, just put them out on the table as you leave. Also, take note that we have 2 other speakers, one in March. Topic is social impact bonds, as Dennis pointed out. And then in May, we are very pleased to have Tonya Allen here, the new president of the Skillman Foundation. So please join us for those. Have a nice day and stay warm.